السلام عليكم طلبتنا الأعزاء. Our lecture today is to complete the second part of gastric disorders. Firstly, this is the normal anatomical cut section of the stomach, showed the upper esophagus, gastroesophageal junction, the gastric fundus, cardia, gastric body, pylorus, antrum, this is the antral part, and this is the pyloric sphincter. Higher power showed the gastroesophageal junction, the squamous lining epithelium, and the mucin secreting columnar epithelium with gastric rugae. Peptic ulceration or peptic ulcer disease. Any ulceration in the body. Ulcer mean discontinuity of an epithelial surface, or there is a breach in the mucosa due to this. In case of peptic ulcer, it is due to the action of acid and pepsin on the gastric mucosa. So acid and pepsin will attack the gastric mucosa, result in peptic ulceration. You remember in our last lecture, there are multiple protective mechanisms of the lining epithelium, including intact epithelium, adequate blood flow, bicarbonate secretion, mucus layer, and prostaglandin secretion by the mucous cells. All these mechanisms are protective mechanism. Any imbalance or any disturbance or any decrease in these secretions or damage to these or imbalance of these normal physiological protective mechanism will result in ulceration. Peptic ulcer is a chronic solitary, that is single. Solitary means single lesion that occurs in any portion of the gastrointestinal tract exposed to the aggressive action of acid pepsin juice, or any part of the gastrointestinal tract, including the lower esophageal mucosa, that is in Barrett esophagus, in the gastric mucosa, and in the duodenal mucosa, or in any part like in the small intestine with pancreatic inlet, like in Meckel's diverticulum, when there is heterotopic or ectopic gastric mucosa or gastric inlet, which secrete acid and acid pepsin juice and predispose the mucosa for peptic ulceration. So peptic ulcer is a breach or damage to the mucosa as a result of acid digestion of the gastric secreting epithelium, whether in the esophagus, stomach, duodenum, and the small intestine. In gastric heterotopia, a most common location of peptic ulcer is in the duodenum. So in normal, this is the normal, there is imbalance between what we call it the normal physiological mucosal defense mechanisms, that are the mucus secretion, bicarbonate ion secretion, prostaglandin secretion, normal blood flow, and intact epithelial barrier. If there is increase in secretion, like in hyperacidity, like in H. pylori infection or Zollinger-Ellison syndrome, any cause for or stress ulcers, physiological ulcers, we discussed them previously. Any cause that result in increase in acidity, increase in acid secretion will result in damage to the epithelium. Other causes including weak defense mechanisms in H. pylori and stress, ulcers, drugs, and steroidal anti-inflammatory and corticosteroid, and smoking will attack or will interrupt or impair the normal defense mechanism like normal blood flow or impaired cyclooxygenase production of prostaglandin or excess or vasoconstriction and so on. Hypoxia. Gastric hyperacidity is important for peptic ulcer disease. Gastric hyperacidity. It can be caused by H. pylori infection. H. pylori infection. H. pylori, what is the mechanism? How H. pylori can produce increased acid secretion? H. pylori secrete an enzymes. One of them is urease enzymes, others are proteases to damage the stroma. Urease enzyme will this enzyme will convert the internal urea into ammonia, split result in production of excess ammonia, and this will neutralize the acidic pH of the stomach. So generation of ammonia from endogenous urea with a resultant of increase the gastric luminal pH. This is a protective mechanism or bacterial protective mechanism to protect the bacteria from the surrounding gastric acidic pH. So the bacteria will protect itself from the acidic pH by generation of ammonia from urea, endogenous urea, and increase the acidic pH. This increase in acidic pH result in what we call it rebound acid secretion. This will stimulate the secretory cells or secretory glands and the chief cells to secrete more acid to as feedback for lowering as a feedback for due to increased pH. So it is called rebound acid secretion. Rebound acid secretion result in increase in gastric acid secretion. Parietal cell hyperplasia. Parietal cell hyperplasia. Yes, this is also can result in increase in gastric acid secretion. Parietal cell hyperplasia. Excessive secretory response also. And impaired inhibition of the stimulatory hormone, as in gastrin, impaired inhibition of stimulatory hormone, as in gastrin, excessive gastrin secretion, as in tumor of these neuroendocrine cells, G cells secreting gastrin, like in gastrinoma. Chronic mucosal ulceration. Peptic ulcer is a chronic mucosal ulceration, most commonly in the it is the most common cause of upper gastrointestinal bleeding. Peptic ulcer bleeding is the most common cause, or peptic ulceration is the most common cause of upper gastrointestinal bleeding that is manifested as hematemesis and melena. The most common site is the proximal duodenum, or the first part of the duodenum, and the gastric antrum. So proximal duodenum and the gastric antrum gastric antrum. This site corresponds to, as we say previously, this is the most common location of, or the most common site of affected by chronic H. pylori associated gastritis, or it is called enteral gastritis, H. pylori. So first part of the duodenum and gastric antrum are the most common location of peptic ulceration. Most commonly, it is associated with chronic gastritis, H. pylori gastritis, and autoimmune gastritis. So there will be increase in acid secretion, and like in H. pylori, and decrease in the protective mechanisms, mucosal damage. So there is imbalance between the protective mechanism and the acid pepsine secretion. Imbalance. Any imbalance between these physiological mechanisms that are normal physiological mechanisms against acid digestion result in acid pepsine digestion of the gastric lining epithelium. The risk factors for peptic ulceration, the risk factors, first, or the most common risk factor, is H. pylori infection. H. pylori infection, very common. H. pylori infection is the commonest cause of peptic ulceration. H. pylori chronic gastritis. Increase in gastric acid secretion. Increased in gastric acid secretion. This can happen in stress ulcers, that is called physiological ulcers, or psychological ulcers. Increased gastric acid secretion also seen in Zollinger-Ellison syndrome, that are hypertrophic gastropathy, and so on. Any cause of increase in gastric acid secretion, or in gastrinoma, that is hyperplasia of neuroendocrine cells, G cell hyperplasia. Decrease in duodenal bicarbonate secretion. Decrease in duodenal bicarbonate secretion. So imbalance of this as a result of hyperacidity. Non-steroidal anti-inflammatory drug. So the most common causes or risk factors of peptic ulceration is H. pylori infection and non-steroidal anti-inflammatory drug. Non-steroidal, especially aspirin and also corticosteroids, can cause peptic ulceration. Corticosteroid impair with normal repair and regenerative capacity of epithelial cells. And non-steroidal anti-inflammatory drug will interfere or inhibit cyclooxygenase-dependent prostaglandin synthesis, impair the synthesis of prostaglandin. Prostaglandin is very important for intact epithelium, for adequate blood flow to the mucosa, and so on. Physiological stress. These are the stress ulcers, like Cushing ulcers, in case of increased intracranial pressure or intracranial hypertension, like in CVA, cerebrovascular accident. Any cause that increase the blood pressure or increase the pressure within the brain, in CVA or tumor or so on, or any cause, result in excessive stimulation of the central nuclei to secrete the vagal nerve, to stimulate the vagal nerve to secrete more acid. So curling ulcer, in excessive burn, in major trauma and major surgery. This is a physiological stress. Whereas the psychological stress, also this is a type or result from excessive vagal stimulation. and sympathetic stimulation result in excessive acid secretion and peptic ulcer digestion, hyperacidity. Smoking is important cause for impairment of normal repair, and smoking will interfere with oxygen supply to the lining epithelium, that is hypoxemia, result in hypoxia to the lining epithelium, which will result in impairment of repair and regeneration and healing of ulcers. Hyperchlorhydria, excess HCl secretion, hypergastrinemia in Zollinger-Ellison syndrome, and hypertrophic gastropathy will be discussed later. Clinical features. Peptic ulcer can be asymptomatic. The common presentation in severe cases may be epigastric burning sensation or burning pain. Characteristically, the pain is few hours after meal. Hunger will aggravate the pain, worsen at night, and awaken the patient at night, and it is characteristically relieved by food or antacid. May radiate to the chest, to the back, to the upper, to the other area, or to the left side, right side of the abdomen. Nausea, vomiting, coffee ground emesis. Coffee ground means bleeding or blood mixed vomitus. Bloating, that is feeling of fullness and feeling of gases or bloating, and weight loss. Pathogenesis, H. pylori infection. H. pylori is a very common infection affecting low socioeconomic status population, rural patients, and patients with low hygiene and sanitation. It can be transmitted by close contact from patient to patient and increased with increasing age. This bacteria colonize the gastric mucosa. This bacteria have many protective or many factors that protect these bacteria and permit this bacteria to proliferate within the acidic medium of the stomach. One of the enzymes is urease. Urease enzyme. This will generate ammonia from endogenous urea, which will result in increase in gastric pH, and with the neutralization of acid, rebound acid secretion. This increase in pH will stimulate the excessive production of acid from gastric chief and parietal cells, despite of hypogastриnemia. There is no excess gastrin secretion from the G cells, but there is lowering of pH as a result of ammonia generation. Another enzyme secreted by the bacteria is protease. From its name, this is important for breakdown and damage of the stroma, mucus, and glycoprotein in the superficial epithelium and within the stroma. Weak mucosal resistance, acid and pepsin digestion of the mucosa, deeper than just the mucosa single. These are features of the peptic ulcers, in which they are sometimes deeper than just the mucosa. Single, it is solitary, not more than one ulcer usually. Punched out. Punched out means rounded, regular border, مثل العضة يعني عضة التفاحة. Punched out. Clean base. This clean base is due to acid digestion. Not like in malignant tumor, there is bleeding and necrosis within the center, but in this in peptic ulcer, the base is clean due to acid digestion. And it is a chronic ulcer. H. pylori infection is the most common type of infection worldwide, about 20% of population. 10% of men and 4% of women develop peptic ulcer disease. This is most commonly on a background of chronic gastritis. Chronic H. pylori associated gastritis is developed. 10% of men and 4% of women develop peptic ulcer disease on a background of chronic gastritis. So H. pylori is positive in up to 70 to 100% of patients with peptic ulcer disease. So many or most of gastric diseases or disorders are related to H. pylori. All of these disorders you see, chronic gastritis, that is a chronic H. pylori associated gastritis. Chronic gastritis associate, so 10%, we say 10% only is autoimmune, negative for H. pylori, and up to 90% is H. pylori associated chronic gastritis. Peptic ulcer disease, gastric carcinoma, gastric lymphoma, and reflux esophagitis. So H. pylori can be isolated in all these types of gastric diseases, starting from chronic gastritis, peptic ulcer disease, gastric carcinoma, gastric lymphoma, and reflux esophagitis as a result of pepsine digestion of the lower esophagus. Put in mind again, H. pylori is implicated in all these types of gastric disorders. They are again gram-negative spiral bacilli or comma-shaped or cocobacilli, spirochetes. They are not invade the cells. They are inhabitant like this. They are inhabitant within the superficial mucus layer. They are extracellular, not intracellular. These, their enzymes, their antigens, and their damaging force is all extracellular, inhabiting the upper mucus layer or within the glandular lumina, not intracellular. Peptic ulcer morphology, the morphology of peptic ulceration. Most commonly we say that is peptic ulcer, 90% is in the first part of the duodenum, proximal duodenum, or lesser curvature of the stomach. It is single ulcer, we say it is solitary, single ulcer, rounded, small ulcer with sharply punched out edges, that is regular, sharp, and well demarcated. It has a smooth, clean base and puckering of the surrounding mucosa. And 4 major, small, usually less than 2 centimeters, in comparison with malignant ulcers. Microscopically, 4 diagnostic or 4 distinct layers: superficial necrotic layer, inflammatory cell zone, granulation tissue, and collagenous scar or fibrous tissue layer. microscopically. To start, I will show you the gross appearance of peptic ulcer or gastric peptic ulcer. It is punched out, well punched out, or well demarcated. So the border is regular, usually ovoid or rounded, regular margin punched out مثل العضة قلنا, and clean base. And these are the surrounding puckering of the mucosa due to lower down fibrosis, and that will pull the mucosa under and there will be pulling of the mucosa from downward fibrosis. So there will be what we call it puckering. Puckering يعني يجي مثل أشعة الشمس, like sun array. Puckering of the mucosa or radiation of the mucosal fold toward the center of the ulcer. Clean base due to acid digestion, and there will be this is a breach, or this is discontinuity of the mucosa and submucosa without reaching to the muscle. One of the complications is perforation or rupture due to erosion of the blood vessel. Again, punched out gross appearance. Diagnostic is small size, punched out ulcer, regular outline and border, clean base, hyperemia, and radiation of the mucosal fold or puckering due to underlying fibrosis. This is the intact epithelium or intact gastric epithelium, and here there is the discontinuity or breach, قطع, in the gastric mucosa, in which there are 4 diagnostic layer or distinctive layers: necrotic layer, chronic inflammatory cell layer, granulation tissue, and collagenous layer. Here the breach is very distinct, very clear. There is a breach in the or discontinuity of mucosal lining, loss of mucosal lining, reached the submuscularis mucosae. The layers, again, this is the breach or ulcer, and the layers are 4 layers starting from upward: necrotic debris, inflammatory cells, fibrous granulation tissue, and fibrous or collagenous layer. Bleeding is related to erosion of submucosal artery, result in hematemesis and melena, upper GIT bleeding, and so on. This is disorders, or this is called or disorganized gland due to reparative process and regeneration and healing process with heavy inflammation, heavy inflammatory cells, again, or active. Again, the layers: necrosis, inflammation, granulation tissue, and underlying fibrosis. Normal gastric mucosa, and here lymphocytes, plasma cells, neutrophils indicate activity, and special stain to demonstrate the S-shaped or spiral H. pylori bacilli inhabiting the upper mucus layer, not within the cells. The complications of peptic ulcer disease is bleeding, upper gastrointestinal bleeding, hematemesis and melena, and perforation also. Bleeding which will result in chronic iron deficiency anemia. The bleeding can be acute, massive, or even fatal, and it is also a surgical emergency, necessitate urgent correction and surgical ligation of the eroded vessel. Fibrosis and structure formation mainly result in pyloric stenosis as a result of healing by fibrosis and ulcer in the pyloric area near the antrum. Perforation of an ulcer result in bleeding and chemical peritonitis. This is also an emergency. And gastric carcinoma, gastric ulcer, peptic ulcer is more more liable for gastric carcinoma than duodenal carcinoma. There is for duodenal carcinoma, which is more common, there is no risk of duodenal carcinoma or a neglected risk. Carcinoma is more with gastric peptic ulceration because it is most commonly on a background of chronic H. pylori associated gastritis with intestinal metaplasia. Again, this is the gross shape of typical peptic ulcer, defined, ovoid to rounded, regular, radiating mucosal folds, clean base, and small size. Again, this is an old peptic ulcer with typical radiation of the mucosal fold due to underlying scarring and collagenous formation. Another one, small sized, less than 2 centimeter usually. Here it is about 1 centimeter with regular border surrounding hyperemia and clean base. Peptic duodenal ulcer. This is the most common or more common site, duodenal ulcer, in the first portion of the duodenum, first part of the duodenum, proximal duodenum. You identify the typical ovoid shaped, regular, punched out with surrounding hyperemia. And as we say, this type of ulcer carry no risk of complication of carcinoma in the future in comparison with gastric peptic ulceration. Endoscopy is very important. Endoscopy, NAVUR, or OGD, is very important to recognize that cause of bleeding or epigastric pain. So this is the ulcer. The yellowish secretion is related to necrotic material. Here it is there are two ulcers, peptic ulcers by endoscopy when they are rounded, regular, without with typical features, bleeding here, bleeding in the center due to erosion of submucosal vessels. That are the causes of upper GIT bleeding. Very important endoscopy. ناظور very important كلش مهم. Gastric ulcer, we say the gastric ulcer is more liable to be malignant than duodenal ulcer. So gastric ulcer should be taken seriously and follow-up is very strict than in duodenal ulceration because the risk of gastric peptic ulcer to become malignant in the future is more and it is most likely to occur or happen on a background of chronic H. pylori associated gastritis. مثل ما قلنا ال H. pylori is a risk factor or a disorder. It is responsible for many gastric disorders, starting from chronic gastritis, peptic ulcer disease, gastric carcinoma, lymphoma, and even Yes, it's chronic gastritis, lymphoma, peptic ulcer disease, and also esophageal reflux disease. Here, the ulcer is large, ugly looking. This type of ulcer is should should be taken in consideration. It is more ugly looking, and malignancy is suspicious here, and likely to be that ulcer is more likely to be malignant because of irregular and elevated margin, bleeding in the center, and also large size. The ulcer here is in the antral location. So multiple biopsy with endoscopy and is important as steps in the follow-up to detect any area of dysplasia, intestinal metaplasia, and adenocarcinoma. Perforation or air under the diaphragm. Air under the diaphragm is a feature or X-ray feature of perforated peptic ulceration. There will be air under the diaphragm. This is the typical picture or typical sign of perforated peptic ulcer. The most diagnostic tool is endoscopy or OGD. Barium meal is contrast will be ingested with X-ray to the patient, and also biopsy is the diagnostic, more diagnostic for detection of H. pylori bacteria, that is the causative agent of chronic gastritis and peptic ulcer disease, and also to detect any features of pre-malignancy and malignancy, that is dysplasia and carcinoma. H. pylori, again endoscopy, special endoscopy and biopsy, and biopsy to special stain to demonstrate these bacteria more clearly. Serology is important by detection of H. pylori antibodies in the serum for H. pylori, and urease breath tests are an old tool in this detection of this bacteria. Here, H. pylori organism will be detected in by special stain, silver stain, to detect the intraluminal spiral bacteria or S-shaped bacteria within the lumen, not intracellular. Again, intraluminal within the glandular lumina. This is an electron microscopy picture to show the spiral shaped bacteria or comma shaped bacteria or S-shaped H. pylori coccobacilli. Again, Toludine Blue special stain to demonstrate these bacteria inhabiting the superficial mucus layer, not within the cells. So there are some points to remember. That is, peptic ulcer is a sore or breach within the lining mucosa of the stomach or duodenum that is result from the attack of acid and pepsin. Any cause of impairment of the protective mechanism or increase in acid secretion result in imbalance between normal physiological defense mechanism and the acid pepsin action on the mucosa. The most common cause of peptic ulceration are main two causes is H. pylori infection, H. pylori chronic gastritis, and the non-steroidal anti-inflammatory drug. There are other less common causes, but these are the most common two: H. pylori infection and non-steroidal anti-inflammatory drugs. Stress is a risk factor. Stress ulcers, whether physiological ulcer, curling, Cushing ulcer, and the psychological stress result in increased acid secretion. H. pylori can be transmitted from one to one through close contact. The treatment is by certain antibiotic and proton pump inhibitor, and is the most effective treatment. Another disease entity called hypertrophic gastropathy, from its name, hypertrophy and hyperplasia. Hypertrophic gastropathy. We say previously gastropathy indicate damage and indicate there is inflammatory process without chronic inflammatory cell infiltration. A group of uncommon condition in which the gastric rugae are enlarged. The gastric rugae, lining folds of the stomach, are enlarged, becomes giant. Caused not by inflammation, but by the hyperplasia. There is hyperplasia of the mucosal epithelial cells. 3 entities, including Menetrier's disease, in which there is hyperplasia. Hyperplasia mean there is increase in the number of mucus secreting cells. Hyperplasia, increase in the number of cells, increase in the number of the gland, whereas hypertrophy, increase in the size. So the name is a misnomer. There is hyperplasia, increase in the number of surface mucus cells with glandular atrophy. The mucus secreting cells are hyperplastic with atrophic glands. Hypertrophic hypersecretory gastropathy. There is also hyperplasia of the parietal and chief cells within the glands. Zollinger-Ellison syndrome. It is related to excessive gastrin secretion in gastrinoma, tumor in G cells in the stomach, or even in the pancreas, secreting excessive gastrin without negative feedback mechanism. Gastrinoma. There is a tumor secreting this gastrin hormone. يعني أكو فد tumor secreting gastrin hormone, so there is no feedback inhibition. يعني ماكو, the tumor is continued to secrete gastrin and this will stimulate more acid secretion despite the high level of excess acid within the gland. So hypertrophic gastropathy, there is enlargement and prominence of gastric rugae. These are endoscopic pictures to demonstrate enlargement or giant rugal folds of the stomach. Due to, and microscopically, there is hyperplasia of the mucus secreting glands in Menetrier disease. It is rare, but the importance of this disease because it sometimes mimic or it look like cancer or infiltrative cancer in endoscopy, so it should be put in mind. So mimic infiltrative carcinoma or lymphoma, also associated with increased risk of peptic ulcer disease because of parietal and chief cell hyperplasia, presented with epigastric discomfort, diarrhea, and weight loss, sometimes bleeding because of risk of peptic ulcer. Protein loss, this is due to hyperplasia of mucus secreting gland, so there will be excess protein loss and hypoalbuminemia, and also prone to metaplasia and carcinoma. Hypertrophic gastropathy, prominence or enlargement or giant rugal folds due to increase in the number of mucus secreting gland and menetrier disease, and hypertrophic hypersecretory gastropathy, hyperplasia of the parietal and chief cells, and Zollinger-Ellison syndrome due to a tumor of G cells secreting excessive gastrin hormone responsive to negative positive feedback of increased acid secretion in the gastric lumen. So prominence of the gastric rugies, giant gastric folds by endoscopy and microscopically, there is hyperplasia, increase in the number of the gland and number of mucus secreting cells. Another important subject is the tumors of the stomach, gastric tumors or tumors of the stomach. In general, tumors are classified into benign and malignant. Polyps are indication or a name for a benign tumor. In general, for any site in the skin or in the mouth or in the another part of the gastrointestinal tract, polyp indicate any elevation or any nodule or mass that is projecting above the level of the surrounding mucosa. Polyp. Any elevation, adenoma, polyp is any elevation or any nodule that is project above the level of the surrounding mucosa. Most of them, about 90% of tumors of the benign tumors of the stomach are non-neoplastic. Non-neoplastic, when we say non-neoplastic, mean they carry no risk of transformation to malignancy. Carry no risk of transformation to malignancy. 90% of gastric polyps, 90% of gastric polyps or gastric benign tumors. Small, sessile means without stock, and multiple in 25% only. Usually, these polyps occur in the setting of chronic gastritis and has no malignant potential on a background of chronic gastritis. They are called inflammatory or hyperplastic polyp. They carry no malignant potential. A tumor of mucosal origin can be benign or malignant and may be presented as polypoid lesion. Sometimes benign and malignant tumors can be presented as a polypoid. Polypoid means projecting or exophytic or cauliflower or so on. Adenoma is a benign tumor. In general, adenoma is a benign tumor of epithelial tissue. Benign tumor of epithelial tissue. It forms only 10% of gastric polyps, 10% of gastric, up to 10% of gastric polyps of the stomach are benign. And 90%, as we say here, 90% are non-neoplastic. 90 are non-neoplastic. That are called hyperplastic inflammatory polyp or fundic gland polyp or Pezjugar اللي هو الهامرتوماتس polyp. هسه نجي نحكي عليها. Adenoma is neoplastic in nature. It is a tumor by itself, but it is benign. has a malignant potential and has a proliferative dysplastic cells sometimes. So its percentage is fortunately low, and it is only form 10% of all gastric polyps, but and many times it carry a malignant potential or dysplastic cells within the base of these cells, of these structures. Another term for gastric adenoma is adenomatous polyps. Adenomatous polyps. They are pedunculated or with a stalk or with neck, mostly in the distal part of the stomach. Distal part of stomach, and up to 40%. In up to 40%, gastric adenoma contain a focus of carcinoma at the time of diagnosis, and the risk of cancer is 3% in the nearby mucosa. Nearby mucosa usually arise in a background of chronic gastritis with intestinal metaplasia. Chronic gastritis with intestinal metaplasia. Again, in the distal portion, in the antrum, that is the typical location of antral gastritis of H. pylori. 40% carry a focus of carcinoma, malignant changes at the time of diagnosis, and in 30% there is nearby in the changes or adenocarcinoma changes in the nearby or in the surrounding mucosa. The risk factor or the preceding factor or the predisposing factor is chronic H. pylori associated gastritis with intestinal metaplasia. We say previously intestinal metaplasia is a precancerous in chronic gastritis. It is a precancerous change of stomach, chronic gastritis with intestinal metaplasia. Again, polyps are forming are benign tumors or benign lesions of the or nodule or mass projecting above the mucosal surface. Most commonly, they are non-neoplastic. Means they are not tumor by themselves. Hyperplastic inflammatory on a background of chronic gastritis. Fundic gland polyp and adenomas forming 10%. Adenoma is neoplastic in nature. Hyperplastic fundic gland polyp are not neoplastic. They are inflammatory. Or fundic gland or hamartomatous or not, in general, they are not neoplastic, whereas adenoma are neoplastic in nature. Other benign tumors, including leiomyoma, benign tumor of smooth muscle, and lipoma, benign tumor of adipose tissue. Malignant tumors, most of the malignant tumors are carcinoma on a background of chronic gastritis with H. pylori, complicating adenoma complicated by carcinoma, and lymphoma, that is tumor of the submucosal lymphoid tissue. It is called maltoma. Maltoma means tumor or malignant tumor of the mucosal associated lymphoid tissue. Mucosal associated lymphoid tissue. There is reactive mucosal or protective lymphoid tissue within the submucosa of the gastrointestinal tract, in the stomach, and in the small bowel. Malignancy or lymphoma of this part of lymphoid tissue or lymphatic system is called maltoma, mucosal associated lymphoid tissue lymphoma, forming up to 4% of malignant tumors of the stomach. Whereas most common type of gastric malignancy is carcinoma, and we will discuss them in details. The potentially malignant, that is according to the behavior, potentially malignant or tumors of low malignant potential, is the GIST, that is gastrointestinal stromal tumor, gastrointestinal stromal tumor, and carcinoid, that is tumor of neuroendocrine cells distributed throughout the GIT. This picture showed the origin of benign tumors from the mucosa, benign tumor, adenoma or hyperplastic polyp, most common one. Here in large font, the hyperplastic because it is the most common. Hyperplastic polyp is the most common. Fundic gland polyp and Pitsjuker, that is hamartomatous polyp, arising from the mucosa. The adenomatous polyp is also arising from the mucosa. This is the neoplastic polyp with neoplastic potential, forming up to 10% of gastric polyps. Muscle leiomyoma from the inner and outer muscle coat. Tumor is leiomyoma. Benign tumor of muscle is called leiomyoma, and benign fatty tissue tumor is called lipoma. Malignant tumor, mucosal malignant tumor, is called carcinoma, originating from the mucosa, from the lining epithelium, and from the lymphocyte, from the submucosal lymphocytes or lymphoid tissue aggregate, is called mucosal associated lymphoid tissue lymphoma, that is maltoma tumor of the submucosal lymphoid tissue. Malignant tumor of the muscle called leiomyosarcoma, whereas malignant tumors of the fatty tissue covering is called liposarcoma. Multiple pictures, endoscopic pictures showed many types of gastric masses and polypoid lesion. Can be benign, can be malignant, it can be lymphoma, can be adenoma. So well demarcation and regular shape seen by endoscopy may indicate polyp or leiomyoma or benign tumor, whereas multiple ugly-looking hemorrhagic foci, necrotic foci indicate malignancy. Usually, this lymphoma is presented as such, as submucosal flattening or submucosal lesion, because this originally originate from the submucosal lymphoid tissue, so it is appear as flattening or not or elevation, or there is no projecting mass, but a thickening of the mucosal submucosal layer. Gastric cancer. Subject indicate or most commonly related to, or gastric carcinoma related to aggressive type of adenocarcinoma arising from the gastric mucosa. Aggressive type of adenocarcinoma arising from gastric mucosa. The types of gastric cancer or types of gastric carcinoma. There is a classification, special classification called Lorine classification to divide or to classify gastric cancer or gastric carcinoma into two main types, that are the diffuse type or undifferentiated type, and the other intestinal type or well-differentiated type. From their name, diffuse type or undifferentiated type, this type or this classification is related to the microscopical features of the tumor. In the diffuse type, it is autosomal associated with autosomal dominant inheritance. There is a genetic mutation of the CDH1 gene. There is inactivation of CDH1 gene. It will be associated with non-functioning or non-functional E-cadherin. E-cadherin, these are surface adhesion molecules that are important for cell adhesion and formation of glandular structures. There will be, with the loss of the function or non-functioning of these adhesion molecule that are E-cadherin, this will result in unregulated division and impairment of tumor suppressor gene function, tumor suppressor function. This will result in increase the ability to spread and invade adjacent structures. The cells will lose their cohesive ability. They are spread easily. They have the ability to spread and invade adjacent structures individually and singly. So it is called diffuse type because the malignant cells are running or invading the adjacent structures singly without glandular formation, without aggregation, due to loss of these adhesive molecules, E-cadherin. This type is very aggressive, can be associated with early metastasis, peritoneal implant, and metastasis to the ovaries, called Krukenberg tumor, and it is more aggressive and resistant to treatment than the other type, which is the intestinal type. The other type is called well-differentiated, from the name well-differentiated, because the tumor still forming glandular structures look like intestinal type gland. This is most commonly occurs on a background of H. pylori associated chronic gastritis with intestinal metaplasia. So it is called due to environmental factor. The risk of mutation is higher in the diffuse type than the intestinal type. So environmental type and environmental factor, number one is H. pylori chronic gastritis. High risk population that are the risk for H. pylori chronic gastritis. Adhesive molecules, intercellular adhesive molecules are still present, result in glandular formation, look like intestinal type glands. So a picture to simplify the classification is like this. This is the diffuse type, or called signet ring cells, and this is the intestinal type, still the tumor forming glandular structures look like intestinal glands. The epidemiology, regarding the epidemiology of the gastric cancer. It is worldwide spreading tumor, most commonly in the Southeast Asia, high in Japan, Chile, Costa Rica, Colombia, China, Portugal, Iceland, Finland, Scotland. Certain countries have higher incidence of this type of tumor, and it is the third most common gastrointestinal malignancy after colorectal cancer and pancreatic cancer. 90% are adenocarcinoma, whereas only 10% or up to 10% are non-Hodgkin lymphoma, as we say previously. maltoma, and leiomyosarcoma, malignant tumors of smooth muscle layers. The etiology or causes, 80% of gastric carcinoma result from H. pylori due to free radical formation. Chronic gastritis, chronic H. pylori associated gastritis, it will be associated with chronic production of pro-inflammatory cytokines, proteins like interleukins, like tumor necrosis factor. This increase in cytokines in favor of increased risk of chronic gastritis associated with gastric cancer and result in free radical release. Dietary nitrate that are food preservatives that are converted by the gastric bacteria into nitrite that are carcinogenic compound. Always encourage fresh fruit and avoid canned and preserved food. Hypochlorhydria and gastric atrophy or chronic atrophic gastritis. This will promote bacterial overgrowth. Gastric acid, decrease in secretion of gastric acidity, or even achlorhydria and autoimmune gastritis. A certain food like starch, pickled food, الطرشي والsalted والsmoked meat هذه اللحم المشوي على الفحم وهذه they are saturated with CO and carcinogenic compound. People who smoke cigarette or use alcohol are more have increased risk, 3 to 5 times risk of gastric cancer. So these are environmental factors. The most common environmental factor is H. pylori gastritis, associated gastritis. Pernicious anemia with in which there is antibody to intrinsic factor and vitamin B12 deficiency. Adenoma is we say that in 40% of adenomas that is a risk of there are carcinoma at the time of diagnosis. Achlorhydria, and this is a feature of chronic autoimmune gastritis. Achlorhydria, in which there is antibody to parietal cells and antibodies to intrinsic factors. Partial gastrectomy, operation of the stomach, partial gastrectomy. Studies found that there is an increased risk of gastric cancer. Certain genetic factors in which there are studies for the first degree relative, family history, and type A blood group. Location, the most common location is the pylorus and entropyloric region. This corresponds to the location of antral gastritis, special for a feature of H. pylori gastritis. Cardia can be involved in certain percentage, lower percentage cardia with this have the risk of extension to the lower esophagus, to the wall of the esophagus, body and fundus. This is can happen on a background of chronic autoimmune gastritis and in the greater curvature to a lesser extent. So the entropylorus is the most common location. The onset or the clinical features, how the patient present what is the presentation of a patient with gastric cancer? Most commonly, it is asymptomatic initially. So the disease, gastric cancer, is discovered and many times it is discovered in advanced stage, in a metastatic stage. The symptoms are vague at the start, vague. Malaise, anorexia, that is loss of appetite, dyspepsia, that is indigestion. With progression of the disease, the more an advancing disease, nausea, the symptoms becomes more apparent, in which there is nausea, vomiting, epigastric pain. So epigastric pain always should be taken seriously. Dysphagia. This is in which there is impairment of passing food from the lower esophagus to the stomach. This is happen when there is infiltration of the Auerbach plexus and resulting in what we call it pseudoachalasia syndrome. Pseudoachalasia syndrome due to infiltration of lower Auerbach plexus of the wall of the esophagus and result in difficulty in passing food from the lower esophagus to the stomach. Weight loss, anemia due to chronic blood loss, melena, that is black tarry stool due to it's a sign of upper gastrointestinal bleeding, and coffee ground hematemesis, bloody vomitus, and dysphagia again. Men are affected more than women, and also the risk is increased with advancing age. Also, the patient have anorexia and feeling, there's another sign called feeling of fullness or history. Very important. The history is very important, in which the patient have chronic history of H. pylori infection, in which the patient eat unhealthy food. So it is a disease of poor population because they are they always consume canned food and unable to have fresh fruits, alcohol and tobacco consumers, and patients treated with H. pylori and have a risk of or have a history of H. pylori chronic infection, gastritis, pernicious anemia, that is on a background of autoimmune chronic gastritis, pernicious anemia, gastric surgery, that is partial gastritis or gastrectomy, and polyps, adenomatous polyp especially. Family history, first degree relative especially, and blood type, especially type A. Another physical assessment in early gastric cancer, one of the features is indigestion or dyspepsia, abdominal discomfort or fullness or feeling of heaviness or dyspepsia that is relieved initially with antacid, and feeling again of fullness and loss of appetite, anorexia, epigastric pain, back pain, and retrosternal pain all can happen, especially in the advancing state. Nausea, vomiting, and obstructive symptoms. That is pyloric obstruction due to obstruction of the pyloric sphincter and by the expanding tumor. Iron deficiency anemia due to chronic blood loss and chronic anorexia and indigestion and so on. and H. pylori associated gastritis. One of the mechanisms is the retained or inability to absorb iron. So iron stay in the ferric state due to the increase in the gastric pH. So ferrous is required or for the absorption of iron. It will be should be converted from the ferric to the ferrous state by the effect of gastric acid and acidic media and hypochlorhydria or in increase in increasing pH and by H. pylori effect, there will be inability to convert the iron into the absorbable form, so result in chronic iron deficiency anemia, palpable epigastric mass felt in advancing stage, enlarged lymph node, especially supraclavicular lymph node, and weakness and fatigue and progressive weight loss again, abdominal mass, ascites due to infiltration or peritoneal deposits, jaundice due to liver metastasis, enlarged virtue node, that is supraclavicular lymph node, special name for enlarged or involved supraclavicular lymph node. Always supraclavicular lymph node should be taken seriously. Supraclavicular lymph node. This node enlargement should be taken seriously. It is most commonly infiltrated by malignancy in whether ductal carcinoma of the breast, whether gastric cancer, colonic, and so on. Blummer's shelf is a mass in the pelvic cul-de-sac that is near the uterus, between the uterus and the ovary in the adnexia. And Krukenberg tumor, this is a special term, Krukenberg tumor. Krukenberg tumor means gastrointestinal tumor, whether gastric or colonic tumor involving or metastasized to the ovaries, most commonly from gastric adenocarcinoma or even from the breast. Laboratory diagnosis, decreased hematocrit and hemoglobin due to iron deficiency anemia, macrocytic, that is in B12 deficiency, or microcytic in iron deficiency anemia. Radiological finding, CT scan demonstrate a mass infiltrating the wall of the stomach. OGD, esophagogastroduodenoscopy, is very helpful with biopsy taking, endoscopic ultrasound finding by endoscopy finding polypoid mass, ulcer, regular ulcer, thickened wall, and so on, obstruction in the gastric outlet or inlet. Morphologically, the lesion or the tumor can be polypoidal or exophytic or fungating or intraluminal or cauliflower. These are terms or descriptive terms to describe the gross morphology of the tumor or the growth. Ulcerating or penetrating. Sometimes the tumor is not projecting, not polypoidal. It is infiltrating the wall, forming an ulcer, penetrating downward into the wall. Or it can be infiltrative or infiltrating serous carcinoma, like called Linitis plastica. This is the commonest and diffuse type. We will discuss it later. Superficial spreading carcinoma. From its name, this type of tumor carry good prognosis because the lesion involving or confined or limited to the mucosa and submucosa without infiltration of the wall, without infiltration of the muscle. 5-year survival is up to 90%. Very good 5-year survival. Superficial spreading carcinoma. And advanced carcinoma, that is stage 4 or with liver metastasis or peritoneal metastasis or distant metastasis, supraclavicular lymph node. Pictures showed the morphological or growth appearance or growth patterns of adenocarcinoma of the stomach. Exophytic, that is elevated or fungating or polypoidal. So there is intraluminal growth of a mass. Flat or depressed or ulcerating. There is ulcer or depressed mass into the wall. Excavating, forming a cavity, ulcer and infiltration of the wall. Exophytic, here the mass is have a growth in the lumen, exophytic growth, and endophytic. So exophytic with this is exophytic and this is exophytic, but this is more advanced and with infiltration or downward and reaching the muscular layer. Linitis plastica, here or called leather bottle appearance. Linitis plastica, thickening, diffuse thickening or involvement of the wall. Excavating, here more advanced than this, in which forming a deep cavity reaching the muscle layer with sometimes fibrosis and structure formation. Multiple pictures showed shown by endoscopy. Here the lesion is well demarcated, punched out like peptic ulcer. This is a benign tumor to compare it with the malignant tumors in which there is areas of bleeding irregularity and fungating lesions. Gastric lymphoma is seen, or maltoma is seen as such, seen as flattened or elevated growth with flattened surface due to submucosal lymphoid tissue lymphoma, that is maltoma. The prognosis of maltoma is better than carcinoma. Benign lesion or benign ulcer, well demarcated, punched out, whereas the gastric cancer can looks very ugly, and gastric lymphoma is seen as submucosal thickening, diffuse thickening. Gastric carcinoma, fungating or polypoidal or cauliflower. Here obstruction, bleeding can be seen. Another picture showed gastric carcinoma. Here this is the serosal surface of the stomach. This is the serosal surface of the stomach with the peritoneal fat or mesonephric fat here. The growth here is seen projecting from the inner surface from the mucosa and infiltrating the outer surface, infiltrating the outer wall, the serosal wall. It is penetrate or invade started from the mucosa, submucosa, and muscular coat, and reached the serosal surface and attached to the serosal fat. Linitis plastica, infiltration. There is no distinct mass. There is no distinct intraluminal mass, but the tumor grows in an infiltrative pattern. There is diffuse thickening of the gastric wall. So the stomach will one of the important symptom or important sign of this type of tumor is repeated vomiting, because the because the stomach will be transformed into rigid tube due to infiltration. It lacks peristaltic waves and peristaltic movement, so repeated vomiting is a feature due to a feature of this tumor, and feeling of fullness and heaviness is a feature of this type of tumor. Linitis plastica, or leather bottle appearance. Leather bottle appearance due to infiltration of the wall of the stomach by the malignant cells. They are infiltrating deep into the wall without intraluminal mass seen by endoscopy, but by endoscopy they see that there is thickening of the wall, there is shrinkage of the lumen of the stomach, and with the associated symptom of the patient indigestion, repeated vomiting, feeling of fullness, and peristalsis. So typically, this is what we call it linitis plastica, or leather bottle appearance, diffuse involvement of the wall of the stomach by the tumor. There is no intraluminal mass. The stomach will be transformed into a rigid tube like a leather bottle. مثل هذا الكيس أو كيس الجلد. كيس الجلد هذا اللي يخلون اللي هو يعني يستعملوه للحليب. هذا الكيس it is a rigid or leather. So the stomach will be transformed into a rigid tube like a leather bottle, with loss of peristaltic movement due to infiltration, and the wall is severely thickened and the lumen is shrunken due to infiltration by the tumor. And here the patient typical symptom is repeated vomiting and indigestion and feeling of fullness. The type of tumor or is the diffuse type. Here the diffuse type or the aggressive type is showed this growth pattern of growth. The diffuse type rather than the intestinal type. So diffused growth pattern, we say that there will be loss of E-cadherin molecule. So the cell will be discohesive. There will be loss of glandular formation, lost the ability of glandular formation due to mutation of these E-cadherin adhesive molecules. The cells have the ability to increase the ability to spread and invade adjacent structures, and to have the ability for peritoneal implant, to be seen in acidic fluid, for metastasis in the ovaries called Krukenberg tumor, for lymphatic metastasis to be seen as a supraclavicular lymph node. So the cells are seen separately or individually running within the stroma of the stomach, like in this picture. Signet ring, it is called signet ring appearance, signet ring cells, signet ring. Like so the nucleus will be pushed pushed to the one corner and to the periphery of the cell. The cytoplasm will be filled with large vacuole similar to signet ring. It is the morphological or it is the microscopical pattern of diffuse type by Laurin classification. Laurin classification divide gastric cancer into two types: the diffused type, which is the signet ring, and the intestinal type. This is the fungating or polypoidal mass, mainly in the antral region, with ugly-looking elevated margin, fungating, bleeding foci, and necrotic foci, with heaped-up margins, regular margins, and large size. fungating carcinoma, intestinal type cancer or intestinal type carcinoma on a background, usually on a background of chronic H. pylori associated gastritis with intestinal metaplasia. Still, here in this type, it carry better prognosis than the diffuse type, in which the tumor still forming glandular structures like intestinal type glands. Still, there is formation of the glandular structures. So there are two main types: the diffuse type with signet ring morphology, single cell invasion, and early metastasis and bad prognosis, and the intestinal type, better prognosis with glandular formation. Does carry a good prognosis than the less. So this is well differentiated, and the signet ring is the undifferentiated type. And thank you. This is regarding this, the last topic about gastric disorders. And thank you.